So thank you so much, the OSNT organizing committee and all the scientific people involved in this webinar series and giving this opportunity to moderate this session. Today's session is related to a very important topic, which is chronic kidney disease management in terms of multidisciplinary care involving the patient as well in this perspective. So CKD, we know, is a major burden. The number of people affected by chronic kidney disease is rising worldwide because of rise in diabetes and hypertension, and with aging population, this has become a challenge for healthcare systems. So an effective management of CKD is not only just the medical management, but it goes beyond this, where a multidisciplinary approach in which we involve physicians, nurses, dietitian, pharmacists, and other subspecialty peoples, and an integrated and approach can really have an impact in patient management. So today it's a great pleasure to have with us Dr. Hind. She's senior nephrologist at Dubai Hospital with an experience of over 20 years in the nephrology field. She's a fellow of the Royal College of Physicians, UK, and she holds also a master's degree in renal transplantation. And she had a long experience in management of CKD patients and involving the patients and their families in their care. And currently, she is also working with University in Dubai as an assistant professor and lecturer. So it's a great pleasure to have you here, Dr. Hind. Please give us this interesting talk on CKD management and multidisciplinary care approach. For the audience, just if you have any questions, please do write in the chat box. And at the end of the talk, we will have also opportunity to have some questions and comments from the colleagues. So floor is yours, please, Dr. Hind.
Thank you very much, Dr. Naveed. Thank you, Dr. Saja. I'm sorry for this technical problem. Today, I will present about the role of patient education in improving the CKD care. What I will talk about the changes of CKD and dialysis population, and when to start dialysis, and what the evidence say, and how we can plan the access, and why one size no longer fit all. And what is the structure of the multidisciplinary education, and what is the modalities patient need to understand. And also I will talk about our experience in Dubai Hospital, which is the renal school, and I will even mention about what is the barriers and challenges which we are facing in renal school. So my first slide that I will talk about the prevalence of CKD in the GCC countries. And as we say that, we'll see that the prevalence of CKD in Oman, actually it is the highest through the GCC, and UAE and Qatar are the lowest reported prevalence for the CKD. And as we know that CKD population is increasing, and about 3 million people are on dialysis globally, worldwide, and that is reported in 2010, and which was estimated that by 2030, this number will be doubling. And as we know that the dialysis was being started in 1940s, and the fistula was being used in 1960s. And that time in 1960s, the patients were usually young, and all when they have only, mostly they have isolated kidney disease and they have minor comorbidities and they always stay long time on dialysis. And that time we were being focusing only on the survival of the patient on dialysis. But slowly through the 60 years, that this it is changed and now become more elderly patient on dialysis. And because they are more elderly, they have major comorbidities, they have multiple systemic disease, and mostly it is cardiovascular, even before that, the hemodialysis. And this will usually limit their prognosis in hemodialysis. So now our ideas of how we look for the dialysis or renal replacement therapy is changed. Earlier, we were being focused on patient survival, but now even we are focusing on quality of life. And as US study is showing that hemodialysis patients are getting older, and 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 nowadays even we can see that the age group which is growing faster, it is even about 75 plus patients they are getting on dialysis. And these three things change when your population or our population ages, so that it will change our ideas about dialysis and how we time dialysis initiation. And because now our goal is different and our ideas is different, and how we can plan the vascular access and peritoneal dialysis access as our patients are aging, and how early we have to educate about our patient about the real options. So, when to start dialysis and what the evidence say? To start the dialysis earlier, we were looking only to the GFR, and most patients earlier were being dialyzed when their GFR was below 10. And even we used to dialyze a patient when their GFR was 10, even they were asymptomatic. But now, because we don't have to only we cannot rely on only GFR, and it is not an absolute indication that if the patient GFR fall below 10 and they are asymptomatic, it means that we have to start dialysis. No, because younger patients are usually less comorbid than elder patients, so they can tolerate low GFR. And you can see patients even with GFR is below 5, but there's very minor symptoms. So our optimal time of starting or initiation dialysis is not only the GFR, it is the GFR, the symptoms of the patient, and the fluid overload. And this what here education comes. So it is our optimal time is when the clinician and the patient agreed for the net benefit outweigh the risk and the burden. So the trial of ideal trial, it's a study about 828 patients through 4 years, and they found they want to compare the patient who were being started on dialysis. Does starting early dialysis is better or we can wait, and what is the difference? Actually, through their studying, they found that um, the median time to start dialysis, if the patient was being started early dialysis, what is early dialysis mean? That when their GFR it is between 7 to 10, and late dialysis it when their GFR it is below 5, they found that there is no much difference in the survivals between the two groups, and it is about like 62% in the early survivor versus 63%. And there is no difference in the cardiovascular event, on the infection, and even on the dialysis complication. So, Metcalfe was studying the patient, and they found they start the mortality rate of the patient who are being on dialysis and the patient who were being started late on dialysis. They found that 90 days mortality was about 12% in patients who are unplanned or started dialysis, but versus that only 3% if we plan and start the dialysis. So starting dialysis is early, is good. It is the planning of the dialysis itself is good. The patient will be ready, prepared for the dialysis. But we cannot say that don't start dialysis and we don't prepare the patient. Because like this, we will increase the mortality of the patient. And the event of starting emergency dialysis, it can happen anytime. So, um, mm, so the GFR, as I said, that is not. So what is the thing that make us decide about starting the dialysis? Actually, we as nephrologists, it is nephrologist attitude is one of the strongest driven for the time of starting dialysis, because the young nephrologists, when they see that the patient has GFR below 10, even with less symptoms, sometimes they start dialysis. But this is not always it is ideal. But we found out now the more expert nephrologists, they are having the sense that or when to start the dialysis, but patient will be ready. And what is the other challenges also that can affect us apart of the nephrology attitude? It is the late nephrology referral. Because late nephrology referrals, it is the direct risk factor for unplanned initiation of the dialysis. So the best thing is for us to start dialysis is the early referrals. Why? Because every early referrals will change everything. The progression rate, the reversible cause that we can see. Sometimes we can exclude triple things which it contribute to the GFR, and we have time that to correct that. And then even we can plan for the dialysis. We found that the patient is progressing to end stage, and if we can create the access, and we can decide with the patient easily about the modality without rush, and even we can. It will also increase the preemptive transplant, and there will be higher rate of preemptive transplant, and this is our goal actually. Access planning. Why one size no longer fit all? Earlier, in CODICO guidelines, in 2006, it was showing that fistula first. So it was that time, the policy was that any patient who's approaching end-stage kidney disease and he will require dialysis soon, we'll put fistula for him. But this was being revised by CODICO committees in 2019 when they found that it is not all patients that they will require fistula. They require dialysis, we have to go and rush and start the dialysis. So we have so many factors, like the age of the patient. The older the patient, not all of the patient, we can go for the access because they will have multiple comorbidities and the prognosis even is worse. Why want to go and hurry for the dialysis? So that the DIGO guidelines in 2019 said that no, we have to line the treatment management or the preparation of patient for the dialysis according to multiple factors. As I said, the age, the treatment goals, what is the comorbidities of this patient, what is the prognosis of this patient, why we have to start dialysis earlier. In a study, they found that the patient who are elderly patients who are above 75 years of age or above 80, they found that the progression or the decline in the GFR is low. So why we have to hurry? And the prognosis of elderly patient on hemodialysis is varies. For example, the patient who are elderly, they have, as I said, multiple comorbidities. They can have end-stage cardiac failure. They can have end-stage liver failure, diabetes. They have respiratory disease. This patient who is 80 years old, who come and walking in the clinic, and he's approaching end stage, or he's in stage 4. So I will tell him that now we can go and create fistula. No, not every patient who is end stage kidney disease, they require that we have to run and go and create fistula. Maybe he will die before even initiation the dialysis. So, and there is a study that also showed that 30% of elderly patients, even fistula was being created and it was not being used. And there is also but some special populations that we have to look that when we can start the dialysis. So the dialysis initiation, it is something selective. Not every patient, as I said, that we have to go and run and start dialysis. For example, the patient whom they have rapid decline in their GFR. This is usually occur in 20% of patients who are requiring dialysis. And patients with risk factor like cardiovascular, diabetes, cancer. This group, delaying dialysis will risk emergent initiation. So like this group of people, we have to think about starting dialysis early. So we can use the validation tools. It is a good way that to predict which patient they need to be started early and which patient that we can wait. Mm. What is the case of a structure of multidisciplinary education? There is three evidence stream and we have only one solution. That, as I said, that GFR, it is not the only predictor that to decide about when to be starting the dialysis. When the patient has low GFR, we have to share the decision with the patient about the starting the dialysis. The other thing that the patient must understand their options, that they have multiple options, that access choice, and they have to decide about what is their priority, and we have to individualize the patient according to their need, according to comorbidities, and according to their illness, and what suit them, what fit them. And we know that urgent start dialysis, it costs lives, and preparation prevents this. So the earlier, the better. And all this, as I said, it will come by patient education. What is the case? Okay, what Kadigo recommend? Kadigo recommend that we have to start dialysis education, as multidisciplinary pre-dialysis education. We have to do it early with structure. We have ideally initiate once GFR fall below 30, and most we have to cover in our education all the modalities of the dialysis, the in-center hemodialysis, the home hemodialysis, the peritoneal dialysis, the transplantation, and even the conservative care. And most must include access placement decision. What is our goal is to prevent initiation of emergency dialysis and reduce the complication. Okay, what is the fourth stage where kidney education is needed? It is not only that when the patient will be in stage 4 or when their GFR is below 30, we have to start dialysis. No, we have to start the education for the patient. No, we have to start education of the patient in multiple stages. At the beginning, when they refer the patient for us, and that time, sometimes they will be stage 3, or sometimes even they are stage 2. We have, from that time, we have to start educate the patient slowly, and we have to let them understand about their disease progression, and we have to try to reduce the progression of their disease. And that time, then slowly we have to continue our education even in the pre-dialysis stage. That time, which it is the pre-dialysis education program, when the GFR is below 30 or 30, that time we have to um, educate the patient about the different modality, and that time we have to plan the access according to the patient condition, and we have to start transplant work. And then we have to continue dialysis, even when the patient continue the hemodialysis, especially in the in-center hemodialysis, so that we can promote their self-care. They can help them that they can go from in-center hemodialysis, hemodialysis to home hemodialysis. And they can, like this, they can share with us their ideas and what they want and what they feel better about it. And even we have to talk also about conservative management, which I will come to it later. And if the patient is on conservative management, it doesn't mean that we don't have to take care of them. No, we have to go ongoing support to them. What is the modalities? As all of us nephrologists, we know that the modalities of patient needed to understand the hemodialysis, the peritoneal dialysis, and the transplant and conservative therapy. So, what is home dialysis? Home dialysis, it is the peritoneal dialysis and home hemodialysis. Actually, these two types of dialysis are still underused, and we have to educate patients more and more about this. They have to know about it, and because there is a strong association between advanced kidney care education and BD uptake. And because the more patients they know about it, the more they will accept it and they will go for it. And several countries now, they reduce PD taxes, or they try to manufacture the PD fluid so that they can more promote for peritoneal dialysis. Why peritoneal dialysis? Because peritoneal dialysis can give us better quality of life, and great overall the cost effective is less than hemodialysis. And we know that with peritoneal dialysis, we can preserve the residual kidney function, and the indication of peritoneal dialysis is same like hemodialysis, but usually we insert the PD catheter only when the patient will, like 10 to 2 weeks when the patient is starting the dialysis. But sometimes when we can put urgent start of PD, and we have in Dubai hospital, which we are called it breaking cycle. Sometimes if the patient, they choose to go for peritoneal dialysis, we can put acutely the PD catheter, and then we start slowly the peritoneal dialysis and the education of peritoneal dialysis itself. Um, in the Gulf area, the PD patient, the number of the PD patient are varies. It is mostly in Iraq, and in UAE it was more than that, but currently it's about 220 patients are our peritoneal dialysis, which we have to emphasize to increase the number of this. What about home hemodialysis? Home hemodialysis, it is a safe and it is established. It is patient-centered renal replacement therapy. And we have, like, for example, in Dubai Hospital, many of the patients who are in the center, we can transfer them to home hemodialysis, especially the patients who are ambulant dependent. And if the patient is young and they are stable and they have any like occupational commitment, or they don't want to come to the hospital, home hemodialysis is the best thing. But not all the patients they can go for. We have criteria for the patient who can go for home hemodialysis. Usually, the clinically stable patient, who's a patient who they don't have any frequent dialysis hypotension or recurrent admission, or they have any vascular access. And usually we exclude the patient who are unstable, especially the patient with cardiovascular disease, or they have recurrent access complication, or the patients who have active infection or uncontrolled comorbidities, or they have unsafe home environment. And so that if this patient are the excluded patient, so we can promote more patients so that they can go for home hemodialysis. Now, what about transplantation? As in the education, the transplantation is the first, usually because this is the best long-term option for the patient with a patient with end-stage renal disease, and it is usually access depend on the donor availability, and evaluation and referral should become early, ideally in the pre-dialysis uh, era that time. And we find that which patient, and we have to speak with the patients and their family about the living donors and the disease donation and the preemptive transplantation. All we have to present for them equally. What is conservative management? This is usually we have only hemodialysis, peritoneal dialysis, transplantation, but now we have the fourth pathway, which it is conservative management. It is conservative management. As I said, it doesn't mean that we'll tell the patient you are not fit for the dialysis and you better that you stay away from the dialysis and we don't look at him. No, this group of people, they need close observation and they have to have full treatment and medical treatment, and we have to share with them and decide with them if conservative management it is the suitable. We have to explain for them and they have to understand. And even in US, they are making now for the fellows like programs that they teach them how to break bad news and how to teach patients for the conservative management. So slowly that patient they will understand, and doctors themselves, the nephrologists, they have to understand sometimes conservative management is the better treatment for this kind of people. And as I said, transplantation, it is the best management. Okay, when conservative management candidate emerge, when we can say that this patient can go for conservative management, usually in the patient who have end-stage heart failure or liver failure, in very frail patient, in the patient who have functional cognitive impairment, or in the patient who are long-term care residents who are in the daycare. These people usually are high risk for hospitalization as the initiation of the dialysis. And these patients their, their survival is very low. And even their benefit from the dialysis will be also not that much. Okay, sorry, there is a study where they compare the patient who go for conservative management with the patient who went for the dialysis, high risk patient I'm talking about. So they found that the patient who were in conservative management and they switched to renal replacement therapy, they found about like 65%. And patients who reach end-stage renal failure, 27%. And even they found that these patients who are, especially who are in stage 4 and they are or early stage 5, they can die before even reaching end stage. So why to hurry and put for them fistula and access? I'm talking about them with about dialysis or renal replacement therapy. This patient, we can close observe them, but the breaking news of dialysis, it has, or conservative management, has to come very gradually. So the patient and their caregiver, they will absorb the idea of the conservative management. Okay, what this tells us? The study tells us that the conservative management number of patients are growing, and it is, as I said, it reflects more in the elderly, multi-morbid patient, and this is usually we see them in the low creatinine clearance clinic, and only 27% of this group of patients whom they studied, they found that they reach end stage, and as I said that many patients who receive conservative management discussed never would have reached end stage renal disease. Okay, what is our experience with pre-dialysis education program in Dubai Hospital? In Dubai Hospital, actually, this program, we start program of end stage of renal school. We are one of the pioneers in the region that we start educating the patients who are pre-dialysis in Dubai Hospital since 2008. And up to now, still we are continuing the same program. And this program, it is from multi-specialty team, like nephrologist, dietitian, hemodialysis nurse, peritoneal dialysis nurse, psychologist, social worker, and even transplant coordinator. And our target, as I said, is all patients who are stage 4 and 5 or below, their GFR is below 30 ml, and what is our philosophy in the renal school? Our philosophy, it is an educational journey. It is not a routine clinic visit that the patient, they come and they go back with a bag of medicine, and mostly they don't understand what is going on, and they have so many questions, and they have fear, and they don't know what is their face. So early education is very important for these people, and it is even associated with low mortality rate after dialysis initiation. Our program objectives that to make more than 70% patients to reduce their emergency dialysis and acute catheter insertion, and our measurable reduction is to reduce the hospital stay, to reduce the cost, and about also our target is to reduce mortality and morbidity impact by less than 30%. What is our toolkit? Usually in our renal school, we are using brochures, which is multilingual, and after we explain to the patient, we give them these brochures about hemodialysis, about peritoneal dialysis, about the vascular access, about transplant option in multiple language. And even we show them videos, especially for the peritoneal dialysis. We show them videos of people who are on peritoneal dialysis and what is their experience with peritoneal dialysis. And even we have illustrated books and dummies, which shows that where we put the PD catheter, where we are putting the fistula, and where we are inserting the catheter, dialysis catheter. What's our measured benefit for the patient? We have active precipitation in this. Our goal it is that the patient has to be actively precipitate in the decision making and to be more confident in their choice. And we want to have to be more adherent to their medication and to be more adherent to the hospital appointment, and we want to reduce the inpatient admission, and to improve the survival of this patient, and to improve, as we know, the quality of life, and by choose the modality which is suit them, which it fit their lifestyle and the patient priorities. And the most important is the emotional support for our patient, so to reduce the burden for them and for their family. The team of, as I said, that this consists of six um, people, and as I said, the nephrologists who are with the nephrologists, nurse educators, the transplant educators, the dietitian, the psychologist, and the PD nurse. And as we know that the nephrologist will be the lead, they will lead the talk, and he will talk about CKD, and he will give balanced advice for all the modalities, and he will guide the patient if they are fit for access creation, like every fistula or PD catheter. He will do the referral and the time, and he will support their decision and educate on the even in the phosphate binders, on the anemia medication. We'll speak to them even about fasting Ramadan, about herbal supplement, and about even water intake. All this we are talking to the patient regarding that. And then we have the most important part, who is the CKD nurse educator, because she will be like she will take the lead, and she will be like coordinator between the patient and between us. And they will follow with the patient appointment with their family, and they make sure that they call the patient and the family members that they have to come, because sometimes very elderly patient, they will come, and they will come with a maid and no family member. The patient will not understand, the maid will not understand. So what is the use? So that's why that they make sure that to inform that please, one of the family members, they have to come. And even they do tours for the patient in the dialysis unit, and they show them the patients who are already on the dialysis, so they can share their experience with them. And they give them the education materials also. And we have the peritoneal dialysis nurse that when the patient, we feel that they are fit for peritoneal dialysis, and they want peritoneal dialysis, which is good, and they feel that them and their caregiver are accepting for the peritoneal dialysis. So the PD nurse, she will come and she will explain for them step by step what about peritoneal dialysis, and she will make sure that they can understand and they are confident, because you tell them that you will do it every day for 10 hours and you will do it alone. The patient will have fear, and even their caregiver, and they usually reject that. So our peritoneal dialysis nurse, she makes sure that the patient understand what is going on and what is peritoneal dialysis, and she ease it for them. And after the patient, even he will choose the peritoneal dialysis, her journey with the patient will continue. Even after starting the peritoneal dialysis, and after she make sure that they are doing it at home, they have her number, and anytime any problem, she makes sure that she will they will contact her, and even she will see them later on in our PD clinic also. Then we have the transplant coordinator, which it is very important, as our transplant is growing in Dubai Hospital since 2019. We involved the transplant coordinator to be part of our education multidisciplinary program, because she will explain for the patient from the beginning about what is transplant, what is the importance of living donation, and what is even disease donation. And she will explain for them and that transplant is the best modality. And she will even refer them, will start if the patient are young and fit for the preemptive renal transplant. Usually the coordinator will transfer the patient to the pre-transplant clinic, and from there the journey of the transplant will be started. And our dietitian is a person or the lady whom our patient really they love. When they come to the renal school, they don't want to much listen to the doctors or the nurse or what is hemodialysis or protein. They want only to know what they want to eat, because they feel that if they will stick to the diet, it will delay their progression of the renal failure, or even it prevent them from the dialysis. So, and our dietitian usually, she make it in a way that she will ask them what is their what is their meals, what is their breakfast, and what is their lunch, and what is the dinner, and accordingly she will guide them what to eat and what to eat, and she will give even for them brochures and to show them that what is the patient what is the food which has high phosphate, high potassium, which it has medium phosphate, and she will reinforce all these things during all the clinic visits so that till they understand what is importance of the diet in their disease. And of
Dr.
course, our
Hind, please,
psychologists.
in few minutes, if we can conclude, so then we'll give time to audience for questions, and we can discuss with other colleagues as well as a comment.
Yeah, sure, sure. I'm finishing already. I'm finishing. You want me to wait or you want me
No,
to
no,
continue?
no, it's okay. Yeah, carry on. Yeah, please finish. Yeah.
Okay, only remain only few slides.
Okay.
Okay, then our psychologist, which is the most important, that it helps the family navigate emotion and their lifestyle and to calm them down and to relieve their depression and anxiety and to help them with the right choice so that they can feel that they are okay with their diet. But in the renal schools, of course, we have barriers which we are still facing it. It is not something that easy that we bring the patient, they listen and they will go. No, we have a lot of challenges that we are facing in our renal school. Challenges that it is in different way. First, we have the patient-related challenges because patient when you tell them you come for education, they feel that they don't want to come. Sometimes because of their fear or transportation or commitment or their caregiver. Sometimes patients they don't want to come, and sometimes because of their anxiety, depression, and even we feel that they have difficulty to decide what modality. And most of the patients they will say that I cannot decide now. So that's why in the renal school, even we give them appointment after 3 months to come on for re-education, and again after 3 months, so that to reinforce all the materials and the educations that they can understand and they can go with us. And this it helps the patient. And as I said, even they go and they meet the dialysis patient, peritoneal dialysis patient, who come for training, or the hemodialysis patient. When they come and they talk to them, they feel better. So that, but still the patients are reluctant and not decision. They are not deciding for what they want to choose. It is one of our challenges in the renal school. The other challenges which we are facing also, it is the education system itself. Sometimes we feel that we are giving the patient too much information that they cannot grab it in one time. And sometimes, patients they come very sick or they are already stage 5. There is no time that they think about what to choose or where to go, because they are too ill to make any decision for dialysis. And sometimes our staff is themselves, they are, sometimes, they are favoring one type of modalities and they push the patient or, uh, unintentionally, they are telling the patient to choose this is better for you or this better for you. And, sometimes the staff themselves, they have lack of knowledge about different modalities in depth. So even the staff, they need also education before we educate our patients themselves. And sometimes we have limited time, for to give all education because, in each time we see the patient for 2 to 3 hours. So we have another patient will be waiting. So this long time, it is really the time also, it is one of the barriers which we are facing in our school. What is the literature say and why it's still getting wrong? We don't have to go by books, especially for the young nephrologists, that this patient, his CKD stage 5, GFR bloated, we have to start dialysis. No, we have to educate. They need to continue in the renal replacement field, not just the pre-dialysis. And we have to continue education of the patient. Before, as I said, from the first day he saw the nephrology, then at pre-dialysis, even post-dialysis, when he start, so that the education and the emotional fear and acceptance of the treatment will be there. And and as I said that at the beginning, that conservative management was important. I think that we are not actually, we don't do it in our renal school, but I think slowly, as we said that our patients are aging, we have to give them education little bit if they are not fit or if they are high comorbidity. This we are doing it for the patient who are inpatient when they refer from other specialty, like from the oncology or from the medical or um, from the gastroenterology for the patient who has end-stage liver failure. We do that. Sometimes we discuss with the family about what is important of uh, what is better for the patient, and conservative management maybe it is better. Mm. So my conclusion that um, the dialysis population is older and more comorbid than ever. And as I said, that our population are aging, we are reaching end stage. So we have to focus on quality of life more than survival. And multidisciplinary patient education, it improves the modality decision making and the access planning, and even it improves the outcome. And as I said, that's a persistent barrier like fear, late referral, and systemic inconsistency keep many patients from benefiting from their pre-dialysis education, and inform and engage the patient and their caregiver about the modalities of renal replacement therapy and about um, insertion of the access in place. It can prevent complication and shorter stay in the hospital and low cost. And as I said, vascular access and prognosis data show that one size fits all. It is not fistula first. It is not accepted for patients who are elderly patients with multiple comorbidities. That we have to think about it before we run and say that we have to do fistula for all patients. And we have to think about the conservative management. And we have, and I said, better target education and decision making would directly improve that picture. And the argument is population change. We know that our population change of the dialysis patient, the time is complex, the access must be individualized, and this all will education will enable all of these three. Thank you very much.
Thank you so much, Dr. Hind, for this really overview on journey of our advanced CKD patients. Um, it's really very important to involve the patients and family in the decisions of selecting a modality over other, and also the timing is very important. I think the education really it matters a lot to convince sometime patient. Um, Before we go to the audience, if they have questions, I will just ask you. In GCC, uh,
Yes,
my experience for last many years and recently in Oman, before in Saudi Arabia, we face really this very often that patients are not convinced till they are symptomatic to start dialysis.
yes,
Not only
yes,
preparation, but also initiation of dialysis.
yes.
So, do you think that which intervention among all these approaches is more successful to really convince them to educate them on more on this? How you can convince them and intervene earlier in this issue?
As I said, doctor, I think that education, the earlier education start, the more that the patient and their caregiver, they will understand or they grasp what is renal failure. Because when they'll be transferred from PHC or from any other subspecialty, they will tell them that you have renal failure or kidney problem, you go to the doctor. And the patient will come in stage 3, for example, to us from that time, or even stage 2 sometimes from that time, from early time, I think that if we start educating the patient slowly about the prognosis of their disease and the progression of the disease, that I think it will help. It will help us that when we reach to the pre-dialysis time, patient, will understand because the gap, between them, and this it needs follow up with the patient also, and they have to come for regular follow up because any gap, between the CKD and the end stage renal disease, that if there is any gap, this will really affect our
The
patient
management.
accepting for the dialysis.
In your clinic, how successful you are, like in this multidisciplinary clinic where you have psychologist, dietitian,
Actually,
coordinators, vascular access coordinators. So you are able to, like in terms of percentage, if I will ask you that, how many
Actually,
patients?
I have a slide, but I think maybe it's missed that because we from 2008 when we start till now we educate more than 1,200 plus patients. But and some of them they went for dialysis with fistula created, and some they went for the PD, and some people even they went for transplant. But we have a good number of people, about 32 to 33%, who they didn't decide till they reach end stage.
Let's say,
So
yeah.
it is not, I will not tell you that it is, yani, that it
Yeah,
solves
you
all
can't
the problem.
succeed 100%, but
Yes,
at
it is
least
not.
you can
No, yes, yeah,
improve the
yeah.
number of patients.
Still,
Yeah, still,
exactly.
yeah.
And yeah, and this one of the way is to bring them again and again, and sometimes they don't come back. You know, they said, no, we listen, we don't want to come back, but
True.
during their other clinic visit, we have to see in their normal clinic visit, we have to emphasize that they have to go for the education. They have to go for the education. But as you said, we have to continue educating the patient. This is the only way. Otherwise, as you said, our people are reluctant and the fear of dialysis and end stage is too much, in them.
True. Anyone from the audience has any comment or questions? Please raise your hand or unmute yourself so we can hear from colleagues. I don't know if anyone from Royal Hospital or Dr. Sajja from SQ, so or anyone from the dialysis centers have any experience they want to share or have any question to ask. Please go ahead. Feel free.
Yes, thank you very much. I am Professor Hisham Said, Emeritus
Yes, go ahead. Yes.
Professor in Shams University School and ESNT President-elect. Thank you very much, Hind, and drive by perfectly by Dr. Naveed. And thanks for sharing your experiences in this field for MEDT. Yes, MEDT will improve the outcome, definitely, especially in patients with comorbidities. I'm just highlighting here that even in developed countries, the adherence to the guideline medical treatment is not reaching 30 to 40%. That's why we have to focus also on the medications of the new medication like Venrinon, like SGLT2 inhibitors, and the ARBs and follow-up, because adherence to this medication is still lacking behind nearly only third of patients who are consistently taking that medication, in particularly who are managed by general medicine or internal medicine, who are may stop SGLT2 inhibitor or ARBs without sufficient time. So I think we have also to expand these experiences in earlier stage GFR above 30 for the general health population. I have only one question here. I have ongoing study on long scale for the patients on maintenance hemodialysis into two groups. One group who are not caring in CKD program before dialysis initiation, and those who are initiating dialysis immediately after reaching the nephrologist. Provisionally studies showing that patients who maintain CKD program before initiation of dialysis had better outcome. It's long time follow-up for around 3 to 5 years, but in general practice, patients who are getting more CKD program prior to dialysis has many advantage of definitely anemia management, CKD, MPD, nutrition support, and etc. So, do you have such a study at your country that compare who initiated dialysis with prior CKD, MEDT program and those against that who are presented to initiate dialysis immediately on a way of outcomes, morbidity and mortality?
Yeah, Dr. Hind, I think you can answer on the second part of the question. I will just, on the first part, yes, I agree that, the data on implementation of these novel therapies or so-called four pillars in CKD management is not fully implemented, not only in the GCC, but I would say also in the West, the adherence is very
Yes,
low.
even USA,
Uh,
yes.
yeah, even in USA maybe. Now we are here in Oman, and in particular in our setup, we have really good collaboration with the polyclinics and primary care setups where they refer the patient to nephrology. In particular, SGLT2, everyone is prescribing in the primary care setups. But regarding
Yeah.
finerenone, it's limited to the nephrology clinic. So we are trying to, recruit more and more patients to all the renoprotective medications, and definitely it will help in future, at least to slow the progression and to minimize the number of, patients on dialysis, hopefully. Regarding the second part, I don't know if Dr. Hind, you have come across any data or any study head-to-head comparing patients with MDT clinics follow-up and sort of those crush landers. We know from international data that definitely the outcome is bad for them. But to my knowledge, I'm not aware any published data in GCC. You want to add
Actually, in
anything?
GCC also, I don't have any data, but there is one study in US. They compare patients who were being started urgently on dialysis with the patient who were being planned dialysis, and they found that 3% for the patient who are planned dialysis, only the mortality was 3%, comparing to 12% to the patient who were being started on urgent dialysis. But as Dr. Navid said, also even in Dubai Hospital, we are trying to educate the physician in the primary care center about medication, the new medication, and even about non-steroidal anti-inflammatory taking, because these people, they will prescribe it like this, yeah, without looking for the patient kidney function, without looking for the comorbidities of the patient and the risk of the patient. So we try to educate these people, about how to take care of the patient from the beginning. Any patient with renal impairment, from that time, from the primary care, the education should be for the physician, so they have to know how to educate the people or the patients themselves.
True, true, true. No, I agree. I think here the patient himself, actually, we try to explain them that whenever they visit any orthopedic clinic or
Yes,
any primary care,
yes,
please inform them about kidney problems and don't get any, over-the-counter or non-steroidal medications. Because
Yes,
sometimes, these patients, when they use, even for a short period, they come to us in the clinic
yes,
in follow up with the progression of kidney function, so in the declining GFR, and that's a big challenge actually. And definitely these clinics, they help to educate them more and more and to be aware about their kidney issues, so they can better preserve and prolong, the kidney function and to delay the dialysis. Thank you so
Dr.
much for your
Naveed,
intervention, Dr. Isham. Yes,
uh,
please.
yeah, just a small comment.
Yeah.
We had a small study, but it was long time ago, maybe in 2010, probably, about our renal school. Okay, we had compared the people who had education and they had chosen the renal replacement
tranquility.
therapy like fistula and BD with those who were in denial stage and or those who presented as acute stage. It was like a small study, but it showed that the rate of patient who presented with overload and require ICU admission and intubation, it was much higher than those who was electively admitted. And it was like a
Educated,
small study, but it was long time ago. It was done
Mm.
Saudi journal at that.
published, yeah.
Yes.
Okay. Yeah, thank you for sharing your experience. Yes, that's actually the most of the small data or studies or published reports that confirm definitely the outcome is worse for those who unplanned start dialysis compared to those we plan them to initiate the dialysis. Yes. Um, Anyone else has any question or comments, please?
Yeah, Assalamu alaikum. This is Dr. Seja.
Hi.
Thank you, Dr. Hind. Thank you, Dr. Naveed
Thank you.
and
Welcome.
Professor Hisham. Actually, if I reflect in our experience in the university hospital, we are kind of like acute dialysis setting. So, and our like outpatient clinic is mainly general nephrology clinic, but we have also GN clinic and transplant clinic. So my question here, if we are we are not like in CKD like setup in the university hospital, but being like I'm seeing the data from Oman, and we are the highest number of end stage like chronic kidney disease patients, and actually we have even maybe higher number of late referral, and also our population are younger compared to the other populations. So whether to translate this like multidisciplinary team approach, or the way school educational program to be in the like specialized clinic, like in integrated clinic, especially with the endocrinologists, with the primary care physicians, especially with a lot of the like preventive medicine available. So I think it's worth to be like maybe work better than accepting such like program in tertiary setting. What do you think?
From my side,
Yeah,
actually, renal school, we started it as a program, but now it is a clinic. Actually, when we bring the patient, all these people, multidisciplinary team, they were there. It is a clinic, they come for it as a clinic. But I agree with you that education has to be earlier because really our subspecialty, other specialties, PHC, primary health care, they have, because sometimes they refer for you patient and they don't know why they refer. Sometimes they refer for you stone. Sometimes they refer for you patient with, cyst. They don't know even why they refer, whom to refer. But I think, as you said, education from the primary care is very important. But for the
yeah.
physicians themselves, then we
Mm.
can continue education for the others.
Yeah, Dr. Sada, to this point, I think we should differentiate between these two groups of patients because in primary care, usually up to CKD stage 3, or I would say up to stage 3B, even they are in follow-up, many of them, because, if all of those patients, they will come to nephrology clinic, we won't be able to see them. And then, of course, the advanced CKD patients where we can see them frequently, we can educate them, prepare them for choosing the appropriate modality, either PD, HD, or transplant. That's fine. And definitely,
There is a clinic, sorry, clinic in specialized يعني clinic in Bosher and in Asib, which they are like subspecialty clinic, not the general local health
nephrology.
centers, I mean.
Okay. Yeah,
Yeah, that's
from
what I mean. Yeah.
Okay. So nephrology clinics from the peripheries,
Polyclinic,
not
yeah.
from the
Yeah.
polyclinics. Okay, yeah,
Yeah.
that's that. No, there definitely, yeah, because if you have a specialized clinic in the peripheries, definitely there all the four pillars should be implemented in these patients, and I think early education should be started there. But in the Ministry of Defense, it's slightly different because we have different polyclinics where majority of patients, because our population mainly they are diabetic and hypertensive. The GN patients or other renal disease related issues, they will come directly to us in the tertiary care. But this group of patients, they follow in primary care till they are stage 3B or stage 4. So then they come to us for anemia management, bone mineral disease management, and preparation for their future renal replacement therapy. So in those group of patients, maybe a collaboration with endocrinologists, diabetologists, and family physicians is very important to implement the guideline-directed medical therapy, which is really now, it's very important to start early SCLT2, finerenone, and of course the ACE inhibitor and ARBs. It's not easy, but I think way forward, that's the goal actually.
Yeah, agree.
Yeah. I think if there is no further comments or questions, we are also a bit above the time. Then we can conclude. Any final comment, Dr. Hind, you want to add?
No, thank you. Only but remember to educate the patient all the time.
Thank you so much, Dr. Hind, for your, this overview and journey of CKD patients till they choose this appropriate modality for them. And thanks all the audience participating in this webinar. And we look forward to see you in another event. I think Dr. Saja, she is the leader here, organizing all the meetings and webinars from the Oman Society of Nephrology. So we'll see you in the next meeting. Thank you, everyone. Thank you, Dr. Saja.
Thank you
And
very
all
much,
the
Dr.
rest.
Naveed. Thank you,
Thank you,
Dr.
Dr.
Saja.